Approaches to retinal diseases. We have a fascinating afternoon session. There are definitely new approaches, including medical therapy, gene therapy, and others. We have a dense program, so I would like to call the first speaker to the podium, Dr. Muna Bende from India. And the talk is on anti-VEGF for macular edema from retinal vein occlusion.
Good afternoon, and thank you for the kind invitation. My talk will be on update of anti-VEGF treatment in retinal vein occlusions. My slides are not changing. No, they're not changing. नहीं, यहाँ पे भी नहीं change हो रहा. There are three main types of vein occlusion: central retinal vein occlusion, branch vein occlusion, and hemiretinal vein occlusion, either of which can be ischemic or non-ischemic. And the basic pathology is caused by effects due to the virtuous triad, which is endothelial injury, hypercoagulability, and abnormal blood flow. And then you have liberation of factors, most importantly, VEGF. And this is a diagram of what happens when there's a vein occlusion. You have partial ischemia, complete ischemia, production of cytokines, VEGF, mechanical vascular leakage, all of which results in macular edema. And various factors can contribute to retinal vein occlusions due to the various changes that occur in the veins. And as we have various factors, so we have various treatments, but probably one which is uniformly applicable across all etiologies is the use of anti-VEGF for complications like macular edema. So today's talk is going to concentrate more on long-term follow-up rather than studies which had just short-term 3-month follow-ups following injections. And probably one of the most important is the long-term follow-up of the Horizon trial, which was basically an extension of the Bravo and the Cruise trials. I think what we need to know is as long as the patient is getting monthly injections, they continue to improve. But when they drop to less frequent visits and less frequent injections, they seem to lose that benefit, more so in eyes with central retinal vein occlusion. And here we see the results of the Bravo trial in terms of visual acuity. And you see in the extension, the benefit drops. Similarly, even for the macular thickness, you see the macular thickness comes down, it's maintained, but as soon as you start infrequent injections, the benefit seems to be lost to a certain extent. And this is more evident in the central vein studies. And in branch vein occlusion, you may get away with 3 monthly injections, but not in central retinal vein occlusions, which was the main conclusion, main important takeaway from this trial. The RESTAIN study was again an extension of the ranibizumab for retinal vein occlusion trials, and they found that maybe less than, say, 71% of patients with branch retinal vein occlusion and 72% of patients with central retinal vein occlusion received their last injection within 2 years of treatment initiation. Again, they found patients with less frequent treatment did better if they had branch vein occlusions than central retinal vein occlusions. Now, this is again extensions, the 24-month result of the BRIGHTER study, which compared ranibizumab with or without laser. And they found that ranibizumab with or without laser did better than laser alone. And here you see the top is the patients who had ranibizumab with laser, with or without laser. And the gray lines are those who had laser alone or laser followed by ranibizumab. And the benefit of the anti-VEGF injection is quite obvious until the last follow-up. Similarly for central retinal thickness. The Copernicus and Galileo studies studied the effect of aflibercept. There was a slight difference between the two. But again here, patients who received intravitreal aflibercept did better than those who had sham. And though you started treatment later, after 6 months, you could, if you were in the sham group, you could move on to the injections. Though benefit was there, it was not as good as starting treatment early. Again, this study supported earlier treatment in cases of macular edema due to vein occlusions. Here again, you see that the benefit of early treatment is significant compared to sham and then switching to injections. The crystal study studied central retinal vein occlusion in edema. And what were the significant results from the study? The visual acuity gain was much better if the vein occlusion was treated less than 3 months than if it was treated more than 3 months. And also the presence of macular ischemia at baseline did not significantly influence the outcomes. But here you definitely see that patients who were treated earlier did better in terms of visual acuity gain. And this is macular ischemia versus no ischemia. Patients with no ischemia did better, but the difference was not statistically significant. And the average number of injections, the mean number of injections over 24 months is something we need to tell our patients is about 13.1 injections over 2 years in these eyes. Now compare the efficacy of the three drugs. Probably the most commonly used injections are bevacizumab, ranibizumab, and aflibercept. And if you were to look at how many patients did better, definitely all three drugs did better compared to sham. But if we look at the ranking, which drug was more likely to give the patient a 15-letter gain? It was aflibercept. Which drug was likely to be topmost as far as change in best-corrected visual acuity? It was aflibercept. And ranibizumab was more likely to reduce the central macular thickness. Again, you see when it's change in best-corrected visual acuity, this forest plot favors aflibercept in branch vein occlusions. Similarly, if it's looking at the number of injections, definitely less with aflibercept, similarly with central retinal vein occlusions. What about combination of steroids and anti-VEGF? There are about 10 studies. I'm not going to each one of them alone. Probably the combination would give a better visual acuity improvement compared to anti-VEGF alone or steroids alone, significantly better than steroids alone. A better macular edema reduction compared to anti-VEGF alone, but no difference when compared to steroid alone. Combination could prolong the average time to the first anti-VEGF re-injection. We know that combination therapy, you may re-inject anti-VEGFs more frequently than the steroid, and probably the combination delays that re-injection. And definitely, the risk of IOP rise is there with both. Surprisingly, the risk of IOP rise was less in patients with combination therapy, no explanation given for that. The Fight Blindness Registry from Australia looked at the 3-year outcomes of treatment for central retinal vein occlusion. And they found that switching of the drug was more common to aflibercept. So most patients were switched to aflibercept if they did not respond. And approximately half the eyes were still receiving injections at the end of 3 years, which is something we need to tell our patients. Again, this is just a table of the 36-month outcomes. And if you see that the visual acuity change was much less in patients who were on steroids, and they had a much better outcome if they were on monotherapy. Here you see patients on aflibercept were less likely to be switched. Whether it is because there was no other alternative is unclear from the study because it's retrospective. Now, what happens if you stop the study? That some patients were suspended therapy more than 6 months. And this could be due to lack of follow-up or because they did not require treatment. But only 65% consistently maintained their CMT if they were off therapy. Coming to newer drugs, faricimab is one of the newer drugs believed to have better durability. And the Balaton and Camino studies studied that. And you see that about a little over half of the patients with branch retinal vein occlusion could go beyond 16 weeks between injections, and probably a little under half of them with central retinal vein occlusion could go beyond 16 weeks. The competitor in this group is AIOS2025-GP24-New, and they had the recent results of the QUASAR study were there, and it showed that AIOS2025-GP24-New given after 5 monthly injections, then going on to an 8-week regimen, the patients did better in terms of visual acuity gain and reduction on CMT. So to summarize, anti-VEGF injections, regardless of the agent, when given monthly, show substantial improvements in visual acuity and CMT reduction. However, long-term follow-up, when you move to PRN, there is loss of the initial benefit, which is more evident in central vein occlusions. Early treatment gives better results. Macular ischemia may not influence the outcome to the extent we believe. Combining steroid and anti-VEGF may give a longer time to the first anti-VEGF injection. About 50% of CRVO patients still need treatment in year 4, and the newer injections may help us to increase the interval between injections. Thank you very much, and I welcome you all to Chennai in July for our meeting.
Thank you very much for this important overview. I believe we have excellent treatments for vein occlusions. If patients do not that well over time, do you think this is mostly due to undertreatment, or is there atrophy of the retina that eventually will limit what we actually can gain with treatment?
I think as far as the studies are concerned and central retinal vein occlusion is concerned, it's mostly due to a drop-off in treatment and that they cannot tolerate a 3-month gap, most cases. Atrophy itself hasn't been well studied. Macular ischemia can cause a problem, but long-standing patients, say if you start treatment after 3 months, 6 months, they don't do well. But I don't think atrophy really has been looked at in the big trials.
Thank you very much. We'll proceed to the next speaker. That actually will be a pre-recorded presentation by Dr. Paikan Saur from China. And the title of the presentation is Masquerades for Retinopathy of Prematurity. And I believe this is being projected. I hope so, at least.
Hi, everyone. I'm Dr. Peichuan Zhao from Shanghai, China. I appreciate the invitation and the opportunity to share this topic with all of you. ROP is a leading cause of blindness in children. The purpose of our work is to identify early lesions, treat them, prevent blindness caused by end-stage ROP and other pediatric retinal disease. We plan to address ROP. However, aside from ROP, what else might you encounter? I will share several stories with you. A baby girl came to us for ROP screening. We noticed something unusual. Upon examining the periphery, we found vitreous opacity with possible retinal lesions and asked the parents to return in 4 weeks. The vessels appeared normal, but the retinal mass grew and became solid. It was retinoblastoma, RB, and we have a specialized team to handle RB cases. She was transferred to our RB team. We should never miss this kind of lesion. Another case involved a 2-month-old premature girl transferred to us for ROP stage 4 to 5. This was her initial visit to our hospital. She had stage 5 ROP in the right eye and stage 4A with vitreous hemorrhage in the left eye. Due to the vascular activity, we performed a subretinal injection of Lucentis in the right eye and an intravitreal injection of Lucentis in the left eye. This is about our surgical technique of subretinal injection of Lucentis. 3 days after the injection, the vascular activity regressed. We performed laser therapy on the left eye, followed by lens sparing vitrectomy for the vitreous hemorrhage and the tractional retinal detachment. After the vitrectomy, the retinal traction was removed. However, there was something in the macula. Fungus infection was initially suspected, but antifungal therapy was ineffective as the lesion continued to grow. Given the diagnostic dilemma, a fine needle aspiration biopsy was performed, which indicated RB. The tumor shrank after chemotherapy, and the retina remained stable without tumor recurrence after 9 years. RB and other tumors can hide in ROP. Always keep the tumors in mind. Never miss them. Another case involved a 2-month-old boy who came to ROP treatment. He was diagnosed with ROP zone 2, stage 3, plus positive in the left eye, while the right eye was normal. Laser treatment was administered to the left eye. 1 week after the laser treatment, we observed a ridge, laser spots, and subretinal exudation. The situation worsened 2 weeks after the laser treatment, and he was transferred to our clinic. During his first visit to our clinic, the right eye was indeed normal. However, the left eye showed severe bullous exudative retinal detachment with tall truss and dilated vessels. Due to the exudative retinal detachment and abnormal vessels, we performed intravitreal lucentis treatment first. 2 weeks after the RVR, the subretinal fluid regressed, and the dilated vessels and telangiectasia indicated Coats disease. All of this reminded us of Coats disease. We performed 2-port endo laser and anti-VEGF treatment, which was invented by our team, and the disease was brought under control, with the condition improving. Let's go back to the beginning. This was a premature boy. The initial appearance mimicked stage 3 ROP. However, the lesions in both eyes were extremely asymmetric. The retinal lesion seemed more like a ridge of vascular tufts rather than typical neovascular proliferation. The subsequent exudation, subretinal hard exudates, abnormal retinal vessels, and non-perfusion areas revealed the underlying diagnosis of Coats disease. Coats disease can occur before the expected date of confinement and mimic ROP, which requires additional treatment and attention. This 3-month-old premature girl was diagnosed with ROP zone 2 stage 3 plus positive and treated with RVR in both eyes. The retinal vascular activity regressed 1 month after RVR. We observed peripheral abnormal vessels and persistent avascular retina in the right eye, and retinal detachment adhered to the lens with VH. The bilateral lesions were severely asymmetrical. However, ROP tends to be symmetric. However, the situation got worse in the left eye with vascular occlusions, retinal ischemia, vitreous hemorrhage, and tractional retinal detachment were noted. Bilateral lesions were severely asymmetrical. We conducted a systemic physical examination of the baby and found skin lesions. Upon examining the parents' fundus and skin, we discovered a positive family history. This was actually a case of incontinentia pigmenti. These photos show typical skin lesions of the disease. 1/3 of IIP patients have ocular involvement, most of which are vitreoretinal lesions and usually asymmetric. There are various manifestations of IIP-associated retinopathy, which can also mimic ROP. Another case involved a 1-month-old premature boy, born at 34 weeks gestation, with a birth weight of 2,250 grams. He was diagnosed with ROP stage 5 or AROP in another hospital. We observed severe retinal dysplasia and retinal detachment in the posterior pole. We arranged FFA for the parents. The mother exhibited fever manifestations, and genetic analysis revealed NDP mutation inherited from the mother. Fever may also masquerade as ROP. In atypical ROP cases, think twice, and fever can hide in atypical ROP. Check the parents, think hereditary in every unexplained vitreoretinopathy. The last case concerned mismanagement. A 2-month-old boy with a small gestational age and a low birth weight was initially diagnosed with ROP zone 1, stage 1, 3 plus positive in another hospital. 2 weeks later, at PMA 39 week, Last one day, the disease progressed to stage 2, pre-plus positive. Another 2 weeks later, at the PMA 14-1 week, we observed extraretinal proliferations, neovascularization, and tractional retinal detachment in the right eye. Despite this, the parents were advised to wait and return a week later. 1 week later, they finally noticed the RD and NV and planned to treat it with anti-VEGF therapy the next day. However, the traction worsened on the day of RVR. After the injection, the baby was transferred to us. 6 days after the RVR, the boy arrived at our hospital. The situation was heart-wrenching. We performed laser treatment on both eyes. Along with lasectomy combined with vitrectomy on the right eye, and simultaneous FFA and supplementary laser treatment on the left eye. The FFA revealed fewer features. After our treatment, the situation was brought under control. What if the treatment had been given at this early stage instead of the later phase? We believe the baby would have had a different outcome. Timely treatment is crucial. For beginners, never hesitate or feel ashamed to transfer the baby when you are unsure about the disease. You are still saving the baby. Last but not least, every disease you can encounter in full-term babies may also be encountered during ROP screening. To summarize, we should carefully examine the retina, including the peripheral retina, and never miss tumors. We need to identify the underlying disease masquerading as ROP, think hereditary in every unexplained brachial retinopathy, and make the right choice for treatment or referral. Remember, you can encounter every disease during ROP screen. Let's work together to combat childhood blindness and create a brighter future. Thank our pediatric retinal team for the work we have done together. Thanks for the kind invitation and thanks for your attention.
We thank Dr. Sauer for the presentation, having led the groundwork here of ROP and masquerades of ROP, including mismanagement. Now we get to the real thing, namely the management of ROP. And I ask Dr. Mangad Dogra to the podium to present on retinopathy of prematurity management.
Thank you for the kind invitation. Slides, please. That's it. At the outset, I would like to thank Asia Pacific Society of Ophthalmology for giving me this opportunity to talk on a subject which has always been very dear to me. And these are my financial disclosures. Once we talk of retinopathy of prematurity, this is emerging as a leading cause of blindness in children, especially in developing and middle income group countries, because in these countries, higher birth weight and heavier babies are developing ROP. So I like this slide. This I especially asked Claire Gilbert and borrowed this slide from her. This summarizes everything. If you look at the top green, the entire developed world, they have a very low incidence of ROP blindness because they have excellent neonatal care and facilities for taking care of ROP. So that's totally different. We are in the red. So red is the danger. And that is where we also, most of the world is. And here the optimal neonatal care is there. Screening programs are not in place, and we are facing big challenges. And that's how we have the highest rate of blindness. And of course, there are still areas like sub-Saharan and others, where we were also a few years back. The babies are perhaps not even surviving, and so they don't have this problem at this time. So the possible reasons for ROP epidemics in these countries are, I think we just got together and had written this a few years back. The basic thing is lack of training among pediatrician nurses to resuscitate these babies and take care of these babies. And poor doctor or nurse ratio, especially. We have a lot of what they call SNCUs in these countries, which are even managed by medical officers. So you can imagine where we are. And the ROP screening and treatment protocols may not be widely followed, or there is a lack of awareness and trained people, those who should take care of that. And this is a big issue which is coming there. So Western screening guidelines, we questioned them, and in fact there was a time, 1,500 grams and 30 weeks or 32 weeks, but we saw that a lot of them are getting missed. This was Anand Vinekar's thesis when he used to be with me, and Subhadra also pointed out, and we could just look at this table. This is something which is happening in our country. So all these yellow studies are from our country, two being from my own center, Sanghi and Tek Chandani. They were with me as fellows, and you can see Subhadra's also, and these are Dressner, you all know, with Michael Tracy and Azuma, and how tiny little babies are developing ROP in those countries. And look at the mean birth weight in our country, and also the period of gestation. So all this led to change in guidelines. So we had finally the guidelines 2 kgs and 34 weeks. Even China has 2 kgs and 32 weeks. And there are other countries like Mexico having 1,750 and 34 weeks. And even in Egypt, it's like 2 kgs and 34 weeks. So I think we have to have country-specific guidelines. That is what is going to help us. And that's how we can screen and find the treatable stage. That's where the whole bottom line is. We are not able to timely find that treatable stage, and otherwise we can have an excellent outcome, around 90% with anti-VEGF lasers or whatever treatment we do. So at this time, the current treatments for ROP include the close monitoring of the nutritional status and the oxygen saturation levels, and that is what is not happening perhaps in many of the countries I mentioned. Peripheral retinal ablation with laser is the standard of, still the standard of care, and anti-VEGFs have come in a big way, and the vitreoretinal surgery for stage 4 and stage 5. So classically it was a diode laser delivered with LIO and near concurrent fashion. That is the way, and if we were not having diode, we were not even permitted to treat, and 90%. But I think what happened with us, we published a lot on this, our group. Now it is 532 laser, the same laser which is used for other things being used for ROP. So you don't need to acquire special laser, and this works equally well as this has been now taken very well all across. This is one such baby as I treated with 532 laser. So what about anti-VEGFs? Anti-VEGFs in ROPs are slowly becoming more available all over the world, acceptable all over the world, not available, but acceptable. The most would treat these days AROP and ROP in zone 1, first with injections. But the problem is late recurrences and systemic adverse events are still a concern, especially some of the time we are giving even multiple injections. What about combination of laser and anti-VEGF? We did write a small, like a narrative about, along with Anand. So the laser after anti-VEGF is not required if the vessel reaches zone 3. There's a gray zone here. Some people would treat because they feel more comfortable. Others, they may just watch. Ideal is deferred laser till the vascularization is progressing without any signs of recurrence. That is the way we should be following them. And an anti-VEGF injection will be followed by much less extensive laser in most cases. Especially the problem is, as we are treating a posterior disease, I think we want these vessels to grow further and then treat them. But the problem is may need GA for bigger babies, because like in India, we still treat most of these babies under local anesthesia. The preferred treatment pattern, I would just like to mention here, this is a recent survey. This was an international survey, but it gives you a lot of insight that anti-VEGFs were preferred for AROP, aggressive retinopathy of prematurity, in 64%, and type 1 ROP in 71%. And type 1 posterior also almost 56%, almost like 50-50. So that is the way the big survey, which involves many countries, are giving us what they found out. The majority use laser as first line of treatment for type 1 ROP in anterior zone 2 or type 1 in zone 3. So that is probably in most of the situation. And laser was preferred for rather than anti-VEGF, second anti-VEGF, as a treatment if there was a need because of the recurrence or persistent avascular, peripheral avascular retina. The preferred anti-VEGF in this was also a bevacizumab for ROP. So current surgical approaches are the scleral buckling, lens-sparing vitrectomy, lensectomy, vitrectomy. I think lens-sparing vitrectomy is something which most of us should perform. This is the window. If we perform at 4A, 4B, we can give excellent results. And this is one baby a few years back I have operated. You can see 4B, you just, how nicely it goes back, and you can achieve very good results. Of course, you have problem. We have most of the time this proliferation happening temporally, so you sacrifice the lens. How do you save that lens? I think we proposed nasal lens sparing with all nasal. This has been published. And if you just stick this cannula nasally in the center and do surgery from 2 sides, I think you can achieve all the objectives, save the lens. If you save the lens, I think that's the biggest achievement, and this is what we have been doing for such cases. Stage 5, we all know the problem is that lensectomy, vitrectomy is required, extensive surgery is required, reattachment may be seen in 1/3 of the cases, but functional results are usually poor, and it is frustrating both for the surgeons as well as for the parents. And somehow we don't have to let them go here. If they go here, I think howsoever the big surgeons we are, we can't really do much help to them, and that is what basically we had seen. There's a late presentation of stage 5. This was our group as well as a group in Delhi, which has shown that it was startling that 86 to 89% of the patients in these 2 series were never screened. Can you imagine? And majority it was the parents who noted that their child is not seeing. And can you imagine, the pediatrician referred none to 8.7%. And this is where it was few years back. We had to create a lot of awareness. And 25 to almost 86% referred by ophthalmologists. That's also late. So in conclusion, higher birth weight babies develop severe ROP in developing and middle income group countries. Screening is the most important to identify treatable ROP. For this, we need country-specific guidelines. Manage all treatable ROP promptly with laser/anti-VEGFs as per the standard of care. And the lens-sparing vitrectomy for stage 4 is promising, and vitreous surgery has poor outcome in stage 5. Major problem is suboptimal neonatal care and delayed screening because of not having trained manpower or unawareness. Thank you very much.
Thank you so much, Dr. Dogra, for the very nice presentation. What is fascinating in the management of ROP, it's not the anti-VEGF or probably even the complex surgeries, but how the multi-speciality collaboration between ophthalmologists and pediatricians has led those kids to be screened and referred to an ophthalmologist in a timely manner. And that is something which, at least although I don't take care of ROP, but from the other big epidemic of diabetic retinopathy, where we're still struggling to get patients into the ophthalmologist, it's a big chance. So Dr. Dogra, you have any thoughts on how you worked it out? Your last but one slide showed very few referrals initially. Now I'm sure it's much more. Maybe even Dr. Subhadra can add from the floor your comments on the multi-speciality collaboration.
Absolutely. In fact, I didn't touch upon that. It starts with the obstetrician. Even the antenatal steroids which are given, they help a lot. And I of course talked about the neonatal care, where of course you need to have a very good care, nutritional, oxygen, even otherwise. That's how the countries in green, they have reached that level. And of course, ophthalmologic or other care which is there later on. The problem is if the babies are not even sent or there's a lack of trained manpower. Look at special newborn units which are now more than 800 in our country. So we are facing a challenge. We were just talking, Subhadra, me, Dr. Lingam Gopal and Parijat, all of us, that we are facing a epidemic of stage 5 coming from those places. So we need to do much more. We have to involve them, we have to train more people, and we have to also make somehow advocacy at the government level to do more for our country. It's a big country.
But thank you, you are doing well, thank you so much. And we'll now move on to the next talk by Dr. Hendrik Skoll. So he is the chairman of ophthalmology at the University of Basel and also a world-renowned expert in inherited retinal diseases. Over to you, Dr. Hendrik.
Yeah, thank you very much for the introduction, and a big thank to the organizers for the honor to present here in Delhi, India. I'm going to present on potential treatments for inherited retinal diseases. Of note, I'm also serving as the Chief Medical Officer of Belite Bio. To date, more than 300 genes have been identified that would cause monogenic retinal disease, but not all of the genes are equal. ABCA4 is the most prevalent disease gene, and it accounts for about 30% of all autosomal recessively inherited retinal dystrophies. ABCA4 has a cumulative carrier frequency of 2.5% in population of European descent. So it's actually rare, but not that rare. The audience is very familiar with Stargardt disease, as it was described by Carl Stargardt in 1909. It's the most common juvenile macular dystrophy, and it can manifest as early as 5 years or as late as 70+ years. You just have seen a fundus photograph, but there's a very nice imaging tool that we use for Stargardt disease, and that is autofluorescence imaging. Not only because it produces such nice images as we see here, but it allows to actually visualize the problem, namely this accumulation of toxic bisretinoids that light up on fundus autofluorescence imaging, and also the consequence of these toxicity to the retina, namely the loss of RPE cells, and that would result in a loss of the signal that we see in the center of the retina. When it comes to therapy development, over decades, there was a lack of outcome measures that we actually could use to test efficacy of treatments, but that has, let's say, cured by the PROXSTAR study that developed outcome measures for clinical efficacy testing. What was the PROXSTAR study? It was a worldwide multi-center natural history study performed in 7 centers in the United States and 3 centers in Europe, with a central coordinating center at the Wilmer Eye Institute and a central reading center in Los Angeles. We had seen patients every 6 months for 2 years and included microperimetry testing for visual function, and for imaging we used a spectralis, and we obtained spectral domain OCT and fundus autofluorescence imaging. In the PROXSTAR study, the PROXSTAR study group was able to quantify autofluorescence lesions with the central reading center and came up with 2 definitions. One, DDAF, definitely decreased autofluorescence, which is a level of darkness compared to the optic nerve head of 90 to 100% of darkness, and a similar lesion that we coin questionably decreased autofluorescence, QDF, with a darkness level between 50 and 90%. And we could now track such lesions over time, and PROXSTAR report number 17, published 2 years ago, could show that there was a mean progression rate of about 3/4 of a square millimeters per year over an observation period of 24 months. So we have an outcome measure, and now we can go into therapy development. And when we think about therapy development in retinal dystrophies, and we think along photoreceptor cell degeneration along the x-axis that we see here, there are 2 major approaches that we can take. Number 1, pharmacotherapy, and number 1, gene therapy. And I would like to present prominent examples of one each. Let's start with pharmacotherapy. This actually is in late phase development for both Stargardt disease and geographic atrophy, and the compound is named Tinlarebant. A little bit of background here. The visual cycle, one of the best understood signal cascades in the human body. It's also called the vitamin A cycle, and we see vitamin A on the bottom right. also called all-trans retinol. And all-trans retinol is needed and actually to produce the visual pigment that you see on the upper left, namely 11-cis-retinal that is part of rhodopsin. And there's this constant recycling of the visual pigment, but it needs vitamin A. And vitamin A is taken up from the circulation. Vitamin A is bound to retinol binding protein 4, that's the black dot on the lower right, RBP4, and also TTR. And there's a specific receptor that is abundantly expressed in the eye, not elsewhere, but in the eye. And that receptor, the RBP4 receptor, allows to suck in vitamin A into the photoreceptors and the retinal pigment epithelium. If the ABCA4 gene is deficient, if it's mutated, then there is a build-up of all-trans retinal that cannot be further processed, and that is very toxic. Plus, there is an accumulation of bisretinoids, including A2E, and these are very toxic. Tinlarebant is a novel once-a-day oral tablet designed to bind RBP4 as a means to specifically reduce retinol delivery to the eye in order to slow or halt the accumulation of bisretinoids. So what's the mechanism of action? We see that here on the lower part of the slide. Tinlarebant binds to RBP4, and this is then eliminated through the kidneys, which means there's less all-trans retinol available for the RBP4 receptor, and that means we have a lowering of vitamin A in the photoreceptors, and that means lowering of toxic bisretinoids. After preclinical development, that led into clinical development, and we see the pharmacokinetic and pharmacodynamic profile on the right that was tested on 13 patients in Taiwan and Australia in an open label fashion. Patients would take 5 milligrams per day, and we see that the 5 milligram dose was effective to reduce RBP4 level by a mean of approximately 80% to baseline. You see on the right, you see how the compound goes up after administration. It stays up there, that's the blue line, and you see the red line is a perfect mirroring and allows to reduce that level to more than 80%. And if you could discontinue the drug, you see that on the right on the graph, then you have a return to baseline also for RBP4. What about efficacy? So the efficacy was tested against a subset out of the ProgStar study. None of the patients that went into the trial had any DDF lesions to begin with. There was only QDF at baseline. And 5 of 12 subjects actually never developed DDF lesions. The ones that developed DDF lesions could be compared to the progression that was observed in the ProgStar study. So you see the progression rate in the left graph in red of those patients that were treated in the phase 2 study. And those patients showed a progression rate of 0.5 square millimeters per year over time, and that was compared to the ProgStar study group, and you see that the progression rate was essentially double in the natural history of pretty much exactly 1 square millimeter over that period of time. And that difference was highly statistically significant. What about safety? The drug was safe and well tolerated in these adolescent Stargardt patients. The treatment produced an 80% reduction of RBP4. There was delayed dark adaptation and xanthopsia as the most common drug-related ophthalmic adverse events. All instances of such AEs were mild and transient, and there were no severe or moderate drug-related AEs reported, and no AEs requiring discontinuation of the treatment. Also, there were no clinically significant findings in relation to vital signs, physical exam, cardiac health, or organ functions. The drug is being tested in 2 registration trials. One is fully recruited. All patients have already completed a 12-month visit. And there's another registration trial called Dragon 2 that is currently recruiting in Japan, in the United States, and the United Kingdom. I would like to conclude with gene therapy. When you think about monogenic disease, that appears to be the most obvious thing to do, but keep in mind ABCA4 is a very large gene, and more than 2,000 mutations have been described in ABCA4 alone. I will present on high-efficiency base editing for Stargardt disease, and that was tested in mice, non-human primates, and human retinal tissue. The most common mutation in ABCA4 is the G2A point mutation G1961E, and that is actually a prominent mutation accounting for about 15% of all mutations in Stargardt disease. And this is a potential target for adenine base editing. So the idea is that we would correct this one spelling error, if you will, in the human genome, namely the G1961E mutation, that would result in now a functional protein that was dysfunctional before. That was tested in human retinal organoids, which are little human retinas grown in the dish for 200 days, human retinal and RPE explants from multi-organ donors, and a knock-in mouse model, a humanized ABCA4 G1961E mouse. This slide is a complex slide, but it shows work over 2 years where the vector elements were improved for editing the efficiency of the construct. On the top, you see that the results in retinal organoids. On the lower half, you see the results in photoreceptors in RPE. And that resulted to an editing rate of about 40% in the most important cells, namely cone photoreceptors. That then went into a non-human primate study. And those primates were operated on with a standard vitrectomy procedure, and the compound was delivered subretinally. In some of the monkeys, the fovea remained non-detached, in others the fovea was detached, so we could compare the two. And this summarizes the results. On the left, we see the efficiency of actually correcting this spelling error, of correcting this missense mutation in the human genome. And that could be achieved in about 75% of the cone photoreceptors. However, and that is shown on the right, in the fovea the efficiency was much lower, and it's still unclear why we did not reach that high of efficiency in the human fovea, which is the most important target, obviously. In summary, the most prevalent IRD gene is ABCA4, accounting for about 30% of all cases. Clinical evaluation of the progression of DDAF has allowed this endpoint to be established for pivotal studies. The pharmacological reduction of the availability of vitamin A to the retina with tinlarebant has shown significant therapeutic effects with very good tolerability in phase 2 studies and is currently evaluated in registration trials with the name Dragon 1 and Dragon 2. And base editing of the most frequent mutation in Stargardt disease, namely the G1961E mutation, developed using human retinal explants, iPSC-derived RPE, and human retinal organoids, currently allows an editing rate of around 75% in cone photoreceptors in the primary retina, with significantly lower editing in the fovea. Thank you very much.
Thank you very much, Dr. Muna.
Doc, I have a question on tinlarebant and the dark adaptation issues. Would you expect it to be cumulative because your studies were all 24 months and these are young patients? So
it's a good point. This would not accumulate. So the concentration of tinlarebant obviously in the blood stays the same, of RBP4 also stays the same in the blood. So in actual fact, patients accommodate to that problem. The thing is that patients with Stargardt disease are used to somewhat reduced dark adaptation in the first place because it's part of the disease process. So actually, the fact that we observed dark adaptation problems was because it was tested, not because patients complained about it, right? But it's part of the mechanism of action. Keep in mind that dark adaptation is a sign of road photoreceptor, let's say, delayed accumulation of vitamin A. The most important in Stargardt disease, obviously, is to save the cones.
thank you.
Yeah, can I ask one question? Very nice talk, and I could see the big difference in the tinlarebant treated arm and the control arm. But after 18 months, some increase in DDAF autofluorescence in the treated arm as well. There's some increase in the autofluorescence. So is that a concern, or do you
It's
think
currently not a concern. We are awaiting the phase 3 data. The study will be completed by the end of the year, and 104 patients have been treated with the drug in the Dragon 1 trial. Regarding safety, by the way, because it's also being tested in AMD patients, more than 400 patients have been enrolled and being treated with tinlarebant. So currently we don't know, because this is based on just a dozen patients with Stargardt disease. We don't know how linear that reduction will be in the future. Yeah.
Thank you so much. We'll now have the next speaker, Dr. Divya Rao, on AI monitoring based on handheld fundus camera. Yes, Dr. Divya. Dr. Divya Rao, is she not here? Okay, then we'll move on to the next talk, which is again a pre-recorded talk, Dr. Hao Tianlin on AI monitoring for retinal diseases. Yes.
Friends and fellows, good afternoon. I'm Hao Tianlin from Zhongshan Ophthalmic Center. Thanks very much to the organizers for this invitation. Today, I'd like to share with you our team's experience in retinal AI. Before the sharing, I'd like to introduce our hospital briefly. JOC is the leading eye hospital in China, serving over 1.4 million outpatient visits annually. We now serve as the WHO's collaborating center for eye care and vision, and host the headquarters of APAO. On the occasion of our 16th anniversary, we are excited to host the International Ophthalmology Hospitals Presidents Summit. We welcome you to reunite in Guangzhou for this prestigious ophthalmic assembly and immerse yourself in the charm of South China. As we know, due to the factors such as population aging, changes in modern lifestyles, and increasing premature birth rates, retinal disease are on the rise. However, ophthalmologists are scarce globally, and the gap between the growing demand for eye health and the limited medical resources is widening. How can we bridge this gap? AI technology, which has emerged in recent years, is an attractive solution. AI won two Nobel Prize in 2024 and has potential to promote the entire medical process. Many AI technology have been developed in recent years for assisting in the diagnosis and treatment of retinal disease. Despite the potential, some studies have reported that the real-world application of AI technology is not satisfactory. AI models' performance significantly decreased in real-world diabetic retinopathy screening scenario, with over 20% of images unable to be recognized and inefficiency. How to apply intelligent technology still faces many challenges. From the perspective of clinicians, we found there are two main challenges. First, poor quality images in the real world lead to significant decline in AI performance. Additionally, there is a lack of effective application pattern. To address these challenges, we have conducted a series of studies. First, the diagnosis of retinal disease is highly dependent on image features, and the quality issues are a common problem encountered by all image-based models when applied clinically. Therefore, we developed a fundus color photography image flow cytometry system that assesses the quality of fundus image from 3 dimensions in integrity, illumination, and clarity. This system enables comprehensive and intelligent assessment of fundus image quality. Further, in view of prominent quality issues in infant fundus photography, we developed a deep quality system which can target enhanced image quality. This system makes retinal rays, arches, vessels, and other lasers features more visible. We also demonstrated that improving image quality can significantly improve the diagnostic accuracy of retinopathy for both doctors and models. After solving the most critical image quality problem, we conducted real-world studies on intelligent technology. To achieve better performance of AI models in clinical practice, we collected representative fundus photography from tertiary hospital, community hospital, and physical examination centers, and developed the intelligent system CARE with over 200,000 images. It can recognize 14 types of fundus diseases. We direct CARE in 35 different medical institutes in China for prospective validation, covering 82% of China's provinces. The results show that the model performed well in different scenarios, with an average AUC greater than 0.95. Part of the diabetic retinopathy technology has also been approved as the first Class 3 medical devices in ophthalmic AI in China. This real-world validation pattern has been recognized by peers. The relevant results have been published in Lancet Digital Health and received many positive reviews. In addition to different levels of medical institutions, we also applied intelligent technology to the screen of fundus disease in the elderly population in rural areas. Compared to urban population, rural population characterized by poor economic conditions, limited medical knowledge, and lack of health awareness needs screening even more. We combined the previous development model with a cloud AI platform to provide seamless service for rural population. In this study, we screened out 1,895 patients with fundus disease, accounting for 60.2% of the total number of people screened. This proves that AI application in rural screening scenarios is feasible and necessary. This is also the first prospective study on AI screening for retinal disease in rural areas in China, and the relevant results have been published in the JAMA Ophthalmology. For more remote areas with even more scarce medical resources, we developed an intelligent ophthalmic mobile vehicle that integrates our developed AI technology with commonly used ophthalmic devices. This provides door-to-door eye disease screening and diagnosis service for residents in these areas. The mobile vehicle has traveled over 180,000 kilometers in China, covering 28 provinces, 108 cities, and serving over 150,000 people. Finally, let's make a summary. We focus on the core issue of how to effectively apply AI in clinical practice. We first address the image quality issues associated with AI application. Then, throughout efforts, we explored reasonable application patterns. The application of AI technology for retinal disease starts from medical institutes, such as tertiary hospital and community hospital, gradually extend to the screen of population in rural areas, and finally providing door-to-door eye disease screening service for residents at remote areas with scarce health care resources. This achieved expansion and syncing of high-quality medical resources. And last, I'd like to thank all the members of Retinal Group in our team for their efforts in the research. This presentation is organized by Li Longhui. Also, thanks to all the kind peers for their help and guidance. Thank you.
We would like to thank Dr. Lin for this presentation, and we will proceed to the last speaker of the session, Dr. Shruti Arepali from the United States. I would like to first thank her very much for keeping up for the whole session. She's sick today, but we wanted to keep the order of presenters, so thank you very much. The topic of her presentation is retinal toxicity of anti-cancer agents.
Thank you. And thank you to the organizers for having me. So today I was going to talk a little bit about something we often see in retina and uveitis clinic and can be difficult to diagnose, but also to manage with our oncology folks for these patients. How do I move forward? How can I move the slide forward? Oh, it's going? Oh, it's just, okay. These are my financial disclosures. Okay, so in terms of background, there are several different types of anti-cancer drugs that we have available to us. For the purposes of this talk, I'm going to focus on three main classes, the newer agents and the ones that are giving us very nice outcomes, especially for our metastatic melanoma patients. So there's three main classes. There's the small molecule inhibitors, so those that work along the BRAF and MEK pathway. There are biologics, so checkpoint inhibitors and tyrosine kinase inhibitors. And then there's hormonal therapy like tamoxifen. All of these can present with various types of uveitis and retinal findings. So first I'll start with the MAPK signaling pathway. So from medical school and internal medicine, we all remember that there are several proteins within this cascade, and they all act upon the following subsequent phosphorylated protein to allow cells to do several different things: growth, differentiation, migration, but then also things like inflammation, angiogenesis, and apoptosis. And when these things go out of whack, that's when we start to see cancer. Now, the two most common mutations within this pathway are between the RAS and the BRAF portion, and those comprise about 70% of mutations. So you can see how here, if we work on a BRAF inhibitor or a MEK inhibitor, which are downstream of the majority of these mutations, they can yield the most favorable results for our patients. So I'll first start talking about the BRAF class. The BRAF inhibitors can be combined with MEK inhibitors, and they can become more potent, but the side effect of this is that you can also have more retinal toxicity. So for BRAF inhibitors, they're most commonly used for unresectable malignant melanoma, and in clinical trials, the most common ocular side effects were uveitis, but the majority of these were treated with topical steroids, and they were allowed to continue on the drug. Now, MEK inhibitors are a little bit different. So when we remember back to that pathway, MEK is a little bit farther down on that cascade, and inhibition at this level can cause more ocular toxicity signs. So initially, trials for these drugs were stopped because patients were developing retinal vein occlusions at a very high frequency. But the toxicity that I want to talk about today is something called a self-limited serous neurosensory detachment, or NSD, which is pathognomonic for a MEK inhibitor-associated retinopathy. The reason I want to bring this up is that most patients who are on a MEK inhibitor will develop this at some point, and when they come to the retina clinic, there's a question of, is this central serous chorioretinopathy or something else? So we'll walk through these photos here to see how we can differentiate. Initially, when you see the patient, they'll usually have these yellow or orange collections within the fundus. Usually they're within the fovea or the macula. When you get a scan through this lesion, you'll see two things. You'll see subretinal fluid, but often you'll also see a small rim of fluid above that between the ellipsoid zone and interdigitation zone, which is somewhat characteristic for this. The other things that you can notice is that the outer segments are thickened, and the choroid is usually not thick. The reason that I bring this up is that it's helpful to differentiate that from something like central serous chorioretinopathy, where you would expect that the choroid would be thicker. And you also see in these patients that almost 90 to 100% of them will develop this at some point when they're on the medication, usually early, and it self-resolves. And as it goes away, their ellipsoid zone stays intact. That's also less common in CSR as well, so that differentiates them. Excuse me. The other things that we can think about are something called paraneoplastic vitelliform maculopathy. The reason that you don't think that this disease is that it usually has multiple PEDs within the macula and the fovea, which is different. You can also think about something like B-dump, but you would usually have pigmentation within the choroid that would differentiate this disease from MEK inhibitor disease. MEK inhibitors are also guilty of causing other retinal vascular changes, so they can cause a breakdown in the blood-brain barrier, and it's hypothesized that they can lead to an increased risk of retinal vasculitis and cotton wool spots, although admittedly much more rare than the MEK-associated retinopathy we talked about earlier. Quickly, I'm going to talk about checkpoint inhibitors. These are huge for the treatment of oncology disorders. They've really changed the lifespan of our patients, and as we put patients on them, we've started to see some of the long-term side effects of this. And I use long-term somewhat freely, but these patients who used to live 3 to 4 months are now living over 2 years. And so while they're on these medications, we start to see the sequelae of the medication. So Again, to review from medical school, we have T cells. They present to an antigen-presenting cell. They have various channels on them that activate each other. They use CD28 to upregulate antigen-presenting cells, but they also use CTLA4 to downregulate. And so that's our body's own trick to prevent autoimmunity. Diseases. What cancer does is it comes in and hijacks that pathway and uses CTLA4 and therefore kind of surpasses through antigen-presenting cells in our immune system. Similarly, there are other cells within our system that cancer has learned to navigate, including the PD-1 and PD-L1 receptors as well. So checkpoint inhibitors come in because then they block this process. So they act on one of those three channels that I just talked about. Checkpoint inhibitors are guilty of causing much more inflammation than our MEK inhibitors. Typically, when we think of checkpoint inhibitors, you think of all types of uveitis. You can get anterior uveitis, posterior uveitis, you can get VKH, and orbital inflammation as well. The tricky thing about this is you're now between a rock and a hard place because your patient has really terrible uveitis, but they're on a life-saving medication. And usually it requires a conversation with the oncologist to use oral steroids and local steroids, but to keep them on this medication for as long as possible. Tyrosine kinase inhibitors are also a type of biologic. They cause less inflammation than checkpoint. Checkpoint is the most common, but they can cause a wide range of findings as well. And then interferon alpha also can cause some retinal vasculitis changes that we can see, but it's much more rare. In terms of hormonal therapy, we have tamoxifen. This is more of an old school drug, but we're always taught to think about this when we see bilateral superficial crystalline deposits. And they can cause a pathology that looks similar to MacTel. So I always talk about this one as well. So in terms of management, we've talked about this already, but if it's mild, you can use corticosteroids. There's no need to alter their medication regimen. But if it's getting worse, you have to talk to the oncologist about, is this truly life-saving? Is this the only option we have? And how can we provide more coverage for the inflammation? And to end, I'm going to end with a case that I saw that taught me the importance of maintaining a very wide differential. Checkpoint inhibitors are really interesting. It's really fun to claim that everything is related to checkpoint inhibitor inflammation or any kind of these cancer drugs, and they should always be on the differential, but this patient taught me a lot. So this is an 82-year-old male who comes in. He has decreased vision in the right eye for the past 2 to 3 months. His left eye is LP to NLP from a remote trauma. He has a history of metastatic cutaneous melanoma, and he's been on a checkpoint inhibitor for 3 months, so he's checking all the boxes. He comes in to see me. His vision in the left eye is poor. In the right eye, it's 20/60. He's got a PCIOL with debris. And when you look in, it does look like he has inflammation here. You see deposits behind the lens and inflammatory deposits as well. And when you look in the back, you see that he has dense vitritis. And so all of us are thinking at this point, this is likely checkpoint inhibitor related toxicity. The problem is he's monocular, so how are we going to treat him? And this is life extending, so what are we going to do for him? These are his fluoresceins and ICG, which show minimal leakage. And his left eye, again, from trauma. So initially we started him on topical steroids. He improved, we talked to the oncologist, and we continued on our way. This is what he looks like when he comes back a month later. So when I see him at this point, alarm bells start going off because instead of inflammatory cells, he has quite a bit of pigment deposition on the lens and behind the lens. And so you start thinking if there's something else that could be masquerading, even though we have this really appealing diagnosis of checkpoint inhibitor uveitis. So we follow him. He continues to develop these pigmented collections within the AC and the vitreous. Because he's monocular, we didn't want to intervene initially, so we treated with topical steroids, but because it kept getting worse, we did a diagnostic vitrectomy eventually because we weren't sure if we were missing an infection or something else atypical. The cells come back with metastatic melanoma to the vitreous. And so for this patient in particular, the teaching points and the learning points is that while we learn about all of these new drugs and we learn about all of the sequelae that they can cause in the eye, including multiple types of uveitis, I always urge us to think about what else could be presenting, even in a situation that seems like it's a slam dunk, like in this patient, metastatic melanoma. And that's all. Thank you for your attention.
Thank you very much for this important overview. It appears to be, it's always beneficial for ophthalmologists to learn from oncology. If you just think about how much the field benefited from anti-VEGF. And along this line, TKIs, right, are in development for neovascular disease,
Yes.
right? Which would mean that what you just presented on side effects on systemic treatment for cancer could become in the future
Yes.
as an ophthalmic side effect for an ophthalmic treatment. So is that something we need to anticipate?
I think always. So anytime a new drug comes to market, I think we're always a little bit surprised about the inflammatory profile. And so I think for TKIs, it'll be no exception and something we have to pay attention to, especially in the clinical trials.
Okay, so let's be prepared for side effects of these TKIs.
Can I ask one question? Nice talk. So on those MEK inhibitors, you showed CSR like pathology on OCT. At least on some of the cases which you shared, the OCT, I didn't see any choriocapillaris compression or pachyvessels. Did you
Yes.
do fluorescein or ICG on those patients? Did you see anything in the choroid?
So I agree. Typically, there isn't choroidal thickening. The point is in the literature before, some people had initially started calling this CSR-like retinopathy, but there's distinct differences, so that's what I was trying to show.
There's one more question over here, yeah?
A very nice talk, and I know you didn't cover it, but we have a lot of our patients on anastrozole and letrozole for carcinoma breast. Some of them do come with CME and inflammation. How do you handle those?
Same principle. So usually the goal is to keep them on whatever life-saving or life-altering treatment they're on. So for CME, we'll start simple with drops and move to injectables. And then you can do short-term courses of oral steroids. It's not ideal, but if it means that they can stay on the medication, that's what we'll do next.
And another one on patients with CML and diabetic retinopathy. We know imatinib can cause, worsening of, it can cause neovascularization, it can cause ischemia. Does it influence diabetic retinopathy as well?
That's a great question. I don't actually know the answer to that. That's a very fascinating question.
Okay, if there are no further questions, I would like to conclude excellent Q&A, and I think we witnessed very important presentations on new approaches to retinal disease, and I would like to thank you for your attention, and I would like to conclude the session.
Thank you.
Thank you, Brett. I'm actually going to meet colleagues of yours, actually, yeah. They wanted to talk to me. I'm very